Hello, and welcome to our last lecture for this week, radiographic procedures of the chest, where we're finally going to get into the kind of nitty-gritty of what you're here for, how to position people for x-rays. This week we're going to be going through positioning for the chest. So there are a lot of different positions that we can put the patient in to get a good image of the chest. First, we have to talk a little bit about normal anatomy of the chest, what it would look like on x-rays, and what things we're actually trying to achieve in our image. So a little anatomy lesson that may be a review for some of you. So for bony anatomy, we've got the sternum right here in the center. There are a lot of different parts of the sternum, the top of which is called the manubrium, and then we have the body and the xiphoid process, the pointy part at the bottom. We've got 12 sets of ribs. Our false ribs are 8 through 12, true ribs are 1 through 7. True meaning that they're attaching directly to the sternum. With the false ribs, they're attaching via this kind of shared cartilage. There is some cartilage that attaches the true ribs to the sternum, but they don't share it with other ribs. We can also see that most of the vertebrae here that we see in the thoracic region are the thoracic vertebrae, T1 through T12. And then right at the bottom where we see some of those floating ribs, we have L1 right below that. So floating ribs sit right at T12 for the 12th ribs. In between each set of ribs, you can also see intercostal spaces. Inter means between, costal means ribs, so those spaces in between the ribs. A little deeper into the viscera within the chest. We've talked about the trachea a little bit. So the trachea is that windpipe that goes down to branch into our primary bronchi. So there's a right bronchus and a left bronchus. Again, we're looking at this as if we're looking straight at the patient. So this is the right lung, this is the left lung. We can also see that there are a lot of different fissures within the lungs. Fissures, remember, just kind of dividers or depressions within things. So in this case, we have 3 lobes on the right side, 2 lobes on the left. The left lung is slightly smaller than the right lung to accommodate for that heart that will sit right in the center. We can also see from those primary or principal bronchi that those will split into even more bronchi and eventually the smaller bronchioles. Bronchioles are just smaller bronchi. At the very, very base of those bronchioles, we'll have alveoli, which are going to do gas exchange. Generally, when we talk about the lungs, what we want to capture on imaging in what is sometimes cut off in poor imaging are the apices or the apex of the lungs. Apex is singular, apices is plural. The apices are where sometimes we have tumors within the lungs that like to try to hide, especially since this is an area with a lot of overlapping bone from those ribs. So it's really important that we're able to visualize those appropriately. The bases of the lungs, because of gravity, is where fluid likes to collect. So if we're considering something like a pleural effusion or somebody that has a pneumonia, we want to make sure we also capture the bases of the lungs, and that the person has an adequate inspiratory effort so we can see the nice bases of the lungs not obscured by the diaphragms. This is a little bit of a review of the anatomy of the heart itself. So you may have learned this in a biology class some time ago, but the heart has 4 chambers, 2 atria, 2 ventricles. Again, we're looking at this like we're looking at the patient. So this is the right side, this is the left side. So the right atrium, the right ventricle, left atrium, left ventricle. You'll notice that half is blue and half is red. That's because we have deoxygenated blood entering into that right side that's then filtered through the lungs via the pulmonary artery, comes back through via the pulmonary veins back into that left side, and now that blood is oxygenated. So deoxygenated blood is coming from the rest of the body via the vena cava, from tissues that have already used the oxygen, recycled through the heart and lungs to be reoxygenated and sent back to those tissues via the aorta. Oftentimes when we're looking at anatomy, especially when we look at abdomen next week, you'll notice that the shape of the person's body that you're imaging will affect the shape and the position of their internal organs. It's not so prominent within the chest, although sometimes you will have a really thin person that has a really thin or small looking heart. But when we get into abdomen, we'll notice that sometimes the stomach or certain internal organs are kind of shifted in certain ways. It's especially prominent on things like CT scans and MRIs, but sometimes we can see these things on X-ray as well. So if somebody is considered hypersthenic, that means that they have a really broad, deep thorax, their thoracic cavity is more short, and they have a larger abdominal cavity. So their organs tend to be shifted to be a little bit more horizontal. We might see the stomach sitting at more of a horizontal angle rather than a little bit more of a vertical angle. An average-sized person is considered sthenic. Average, moderate build. This is usually a textbook anatomy type of case. Hyposthenic is slightly on the slender side, so they'll have a long, kind of shallow thorax, a more narrow abdominal cavity, and somebody who is asthenic is very slender, very frail, and the organs will be nearly vertical. So it's the opposite of our hyperesthenic, where we have more horizontal organs. So here's an image where we can see some of that. This is the heart, this is the stomach. And I think it's most prominent in the stomach, although we can see a little bit of the drooping of the intestines as we become more asthenic. When we talk about a good X-ray, we talk about the exposure level of the image. So if an image is underexposed, that means we didn't shoot enough X-rays at the individual, at the image receptor, to penetrate the structures to visualize a good grayscale. So sometimes it'll appear too light. We'll see a lot of white, not a lot of contrast. On the flip side, an image that is overexposed has too much contrast. It's like you're editing a picture, you turn the contrast way up, and now we see not enough grayscale, but for a different reason. We just see black and white, not a lot in between. So on a typical image, we're looking for those blood vessels, the hyla on either side, that are going to supply the lungs. We can't really see those here. And if something were like more of a subtle tumor or a pneumonia process, we wouldn't be able to see that either because we just kind of shot straight through it. Too much X-rays. So oftentimes those will appear too dark. Sometimes you'll hear the term burnt out, but you'll be missing some anatomy. So we've talked a little bit about how to prep for imaging. The same applies for chest imaging. So they'll want to remove any metal from the imaging area. So if they have any necklaces, they should take those off. If they have any dangly earrings that are going to be in the image, then they should take those off. If they're studs, we don't care. They should also take off any bras with underwire. And sometimes you'll have to kind of inspect the clothing too. There will be random zippers or random kind of bejeweled elements of the shirt or jacket, whatever they're wearing. If there's anything metal at all, it's safer to take that off and have them put a gown on. So the first image that we're going to talk about, the first setup, is P to A and A to P chest. This is what a good P to A or A to P chest would look like. It's hard to say whether it's P to A or A to P, but remember we kind of talked about that element of magnification. The heart looks like a really good size here. It doesn't look necessarily magnified, so I would guess this is probably a P to A chest. Although it's hard to say because a lot of the structures will be superimposed in regardless, so it's hard to say which position the patient's actually in unless you're there. But remember, P to A means that the patient's chest is actually facing the image receptor. They're facing away from the X-ray unit, from the tube. And if they're A to P, then they're facing the tube, their back is to the image receptor. So let's go over a little bit of the anatomy that we're looking at here on a typical P to A or A to P chest. We can't really see a ton of the sternum here. There's a lot of overlapping with the mediastinum, the sac that holds the heart and a lot of other structures. But we can see the clavicles on either side, your collarbones. We also have our scapula that are nice and out of the way, and the humerus, the first long bone in the arm. We see a lot of the cervical spine in the neck. So this right here is T1. So this is the start of the thoracic spine. We know that because what you'll learn when you start to learn anatomy in the spine is that there's these little projections off to the sides called transverse processes. And in the cervical spine, they point downward. And in the thoracic spine, they point upward. So that first one that's pointing upward there is T1. And we could, if we wanted to, count all the way down to T12. It's just a nice way of knowing exactly where you are in the spine. On either side of the spine there you have pedicles. They're connecting the rest of the kind of posterior aspect of the spine of the vertebra with the rest of the transverse processes. And then right in the center, that little circle there is the spinous process. So each vertebra will have pedicles on either side. They're kind of like eyes, and the spinous process is like the nose. You can kind of think of transverse processes like the ears, like Dumbo ears. So then we have the ribs. So what I like to do is count the ribs because we can kind of see the posterior and a little bit of the anterior part of the ribs. Remember when we looked at that skeletal diagram, we saw that there was a little bit of cartilage anterior that was connecting the rib with the sternum. So as it becomes more anterior, we're not going to be able to see a ton of the anterior rib because that's cartilaginous and we can't see cartilage on x-rays. But if we start up here at T1, we know that's where our first rib comes off of, and that's where I like to count ribs. It's important to count ribs when we're looking at x-rays because a really good x-ray of the chest is going to have 10 ribs visible. So we'll look at one side here and go 1, 2, 3, 4, 5, 6, 7, 8, 9, and then there's the 10th one. We can still see more ribs underneath the diaphragm, but 10 ribs visible in the lung field is really great. That means that they took an adequate inspiratory effort. That means when they took a nice deep breath in and held it, it was enough that we could see the amount of chest that we need to see. We could trace that rib all the way around. It gets a little confusing though when we get into the anterior aspect as to which rib is what. So as long as you can count those posterior aspects of the ribs, it's probably easiest to do it that way. We can also do the same on the other side. We can count from 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So that's perfect. When we're looking at the diaphragm, there is only one diaphragm, but we call them hemidiaphragms because we're looking at them on either side of the patient. And it's important to look at them on either side because the left hemidiaphragm tends to be a little bit lower than the right because we have this nice liver here that's kind of bolstering up that right side. All right. So we have the right hemidiaphragm and the left hemidiaphragm. And we also have angles that the diaphragm makes with both the ribs and with the heart. So remember, this is our heart within the mediastinum. So remember, costo means rib. Phrenic actually means diaphragm. So these are costophrenic angles on either side. So we should see nice costophrenic angles that are nice and sharp. And then nice sharp costocardiac angles. Cardiac means heart as well. So costo is rib, cardiac is heart. Costocardiac angles on either side, nice and sharp. We've talked about the chambers of the heart. So remember that the atria are on top. So the right atrium is here, left ventricle is here. And it's kind of hard to see where exactly the right ventricle is because there's a lot of overlying structures, as well as the left atrium. We can tell that this is likely a female patient because we can see some of the soft tissue forming the breast shadow on either side. It's important to evaluate that you can see both of those unless a patient has a history of a mastectomy or a different congenital condition, which would sometimes present with a lack of a breast shadow on one side. We can also see this dark area. Remember, dark on a chest, we're looking at air. So this is a radiolucent area right in the center. That's where the trachea is. And if we follow along the trachea and we look really close, we can see where it splits. So this radiolucent area is going one way, This radiolucent area is going the other way. So remember that the trachea is going to split into the primary bronchi, the right bronchus and the left bronchus, and the area that it splits, that fork in the road, is called the carina. We also want to look for the main kind of bundle of vasculature on either side. So generally it kind of looks like a finger or maybe like a tree sprouting within the lungs on either side. So this is the right hilum and the left hilum. There's one on either side. We can also see this kind of area that kind of is a knob coming out right above the heart. That's called the aortic knob. It's just right where the aortic arch is kind of curving around. So that main principal artery that's bringing that oxygenated blood out of the heart to the rest of the tissues. So if you're a flashcard person, this is a place where you should probably make flashcards. These are all things that you'll have to memorize and be able to perform based off of this information. So when we're setting up a P to A or an A to P chest, we're going to use an image receptor that's 14 by 17 and within a grid, meaning that we're putting it inside the machine. We're going to set the SID to 72 inches. Remember that you'll have to convert that to centimeters when you take your competency exam. So refer back to that last lecture for that centimeter conversion. The patient position is upright if possible, but depending on your area that you're working in, it may be seated. The positioning of the part, so we're going to want to make sure that the image receptor's upper border is about 1.5 to 2 inches above the shoulders. We're going to center the mid-sagittal plane to the center of the imaging receptor, have the patient stand straight, chin up, relax their shoulders, and rotate their shoulders forward toward the IR. Their chest will be facing the IR for P to A and back facing the IR for A to P. I know it's super wordy, and there's a video posted of this setup too, but we're going to go over this on Wednesday in person, so you'll have a chance to see what that looks like. It's a lot easier to show rather than tell, but that's the words, so that you have the words, you remember how to set it up. Your patient instructions, you're going to ask them to take a nice deep breath in, out, nice deep breath in again, and hold it. A full inspiration. And you'll want to make sure that the central ray is perpendicular to the center of the imaging receptor and at the level of T7. Remember, a way that we can find T7 is to palpate using our fingers. We can palpate the shoulder blade, and right at the bottom of the shoulder blade, that'll align to T7. So that's how we find those spinal landmarks. Basically, this will be right in the center of the chest, though, so that should also help you. Collimation should be 14 by 17, or if the patient's much smaller than that, you can collimate tighter. So I'll show you how to do that on Wednesday. Indications for a P to A or A to P chest, maybe the patient is suspected to have pneumonia, COVID, they have a cough that just won't go away, shortness of breath, or chest pain. So they'll ask for a P to A or A to P chest based on that. This is the position of the patient. They kind of have their arms winged out at the sides, with the backs of their hands kind of on their hips. This gets the scapula out of the way so that it's not obscuring our lung fields. If we were to pull out the tray that's holding our imaging plate, we'd be able to see that their shoulders are about 2 inches above that. Or rather, the imaging receptor is 2 inches above their shoulders. The set it backwards. If we were to shield, we could shield around the gonadal region. But like I said before, generally that's not something that's really indicated anymore. So, evaluating. When you do your competency for this, if you were to pull this card, you'll make sure that you have collimated appropriately. You have the entire lungs in there, the apices are present all the way to the costophrenic angles. So when we're looking at the shoulders, if there's light touching those shoulders and above the shoulders, the apices are there. Anything that the light touches, kind of like Lion King, is what is going to be exposed to x-rays. You want to make sure that the patient's not rotated at all, that they're facing as far forward as possible, and that they're as close to the imaging receptor as possible. You don't want there to be any gap between them and the imaging receptor. If there's a gap, that can cause magnification, and as we know, that's not good. We talked about the scapulae, we talked about proper inspiration. We want to see those 10 posterior ribs. We want to see a sharp outline of the heart and diaphragm if you were to expose the patient. And we want to be able to see that faint shadow of the ribs and superior T-spine through the heart shadow, and nice prominent pulmonary vascular markings, not underexposed, not overexposed. So this is what a perfect P to A chest looks like. Although this person has even more than 10 ribs showing, that could be due to a certain medical condition that they have, or could be due to the fact that they were just able to take a really nice inspiration. The only thing that I would say on this one is that the left marker is overlying anatomy. Although we're not looking at the clavicles, radiologists are required to report on anything that they see in the imaging. So even if we're taking this for the chest, which we are, they are not going to like it that there's a marker overlying anatomy that they're supposed to talk about. So it'd be best if it were up in the corner in that airspace that we're not evaluating. But nice ribs, we can see the hyla on either side, we can see that aortic knob, really nice trachea, carina where it splits into those bronchi, heart shadow, hemidiaphragm on either side, nice shoulder girdles, and we can see the apex of the lung on either side, the apices. Nice costophrenic angles and costocardiac angles. This is a not so good image of the chest. So in this one, the patient's definitely rotated. We can tell because here's clavicle and here's also clavicle. So it's almost like they're shrugging their shoulder on one side. It could be that the patient was in a lot of discomfort. It does look like they do have some lung pathology here, maybe some pneumonia. But their head's also rotated. We can see that their chin is facing a different direction. And we definitely don't have 10 ribs present here. So a really short inspiration effort. We don't have a really nice contour of the heart. I would guess that this is, it says it's A to P. Because the heart looks a lot more magnified than it does in this image. So that's first, P to A or A to P chest. Next is lateral chest. Our anatomy is going to look a little different here. We're looking at a different perspective. So we can still see a nice apex of the lungs. We can still see the trachea here in front. They do have air in their esophagus, so it's possible that maybe they have to burp, or maybe they have pathology of their esophagus where it stays a little dilated, but generally you won't see a ton of air there. It should collapse when it's not being used. Their sternum's here in the front, so we can see their sternum nice and easy there. The hyla will kind of superimpose, so we see them stacked on top of each other here, and we're looking straight on at a bronchus where there's air coming out of, so that's what we can see there. But all these kind of streaky things are blood vessels, the hyla. We can see a lot of the ribs. We don't have to count the ribs on a lateral. Generally, the rule when we take imaging is one view is no view. There are definitely exceptions to that. But in order to see different perspectives of the same condition, generally more than one view is ordered at a time. Sometimes providers will just ask for a P to A chest, but oftentimes you'll see it accompanied with a lateral. You'll see in some courses, or later on in this course also, we'll talk about minimal diagnostic series, where there's a certain amount of different views that we'll look at for a certain body part in order to make it diagnostic quality. Make it so that when you send that to the radiologist, they're able to make an accurate diagnosis based off of those specific positions. So, suffice it to say, if you have a lateral x-ray, you definitely have a P to A. So you've already counted the ribs on the P to A. We don't have to worry about them on here. We can see the heart shadow here. It's kind of at an angle. The diaphragms, remember, one's lower than the other, so that's why we see them at kind of an angle to one another. We can still see costophrenic angles. These are posterior rather than the lateral ones that we saw before. And one thing that's super important, notice that we don't see arms at all. Arms are out of the way. So generally we have this bar that sits above the patient when we're positioning somebody for a lateral chest x-ray that they'll hold on to, so those arms are nice and up and out of the way. If they put their arms in front of them, sometimes some places will call that adequate, but the problem is a lot of the times when we're looking for lung masses, we're looking for these spaces, retrosternal space right behind the sternum and the retrocardiac space, because they should be nice and clear and radiolucent like they are right now. Sometimes masses will like to hide there. So if we have the arms in front of them and they're superimposing over those spaces, it's not always the best quality of image. So if possible, if the patient can do it, it's best to keep those arms over the head holding onto that bar. If patients also are a little unstable, it can help to hold on to something. We also have the vertebrae here. We can see a nice thoracic spine, and then those ribs that are articulating or forming a joint with the thoracic spine coming off of them. So again, make sure that you know this slide word for word as best as possible. A lot of this stuff is going to be overlapping with the P to A. So general rule of thumb, the SID for a chest is going to be 72. The size of the IR is going to be 14 by 17 and grid. So those are things that you can just remember for chest in general. You don't have to remember for each different setup. Again, we're going to do this upright if possible. It can be seated. It can be in a true lateral position. They will be in a true lateral position. And the left side will be closest to the IR. Why is that? Remember that the heart is on the left side of the body. So if we position them with their right side closer to the IR, we're going to get magnification. So again, the rule of thumb, put the body part that you're trying to image as close as possible to prevent magnification to that IR. You want the mid-sagittal line parallel to the IR, the shoulder touching the IR, and the upper border, again, about 1.5 to 2 inches above the shoulders. So again, that is pretty standard for both P to A and A to P and lateral chest. Again, we're doing full inspiration, so we'll instruct them to take a nice deep breath in, all the way out, back in again, and hold. The central ray will be perpendicular to the center of the IR and at the level of T7 in the mid-coronal plane, so it'll be kind of bisecting the chest in half. And again, kind of at that level of T7. What I find kind of helpful is that you can position them P to A first. If you wanted to use T7, that inferior angle of the scapula as your palpation marker, you can position them there, set the central ray, and then turn them to the left with their left side touching the IR. That way you already know that it's set to that level, and then you can just position the patient appropriately. Again, collimation is going to be 14 by 17. Oftentimes you will make this a little smaller, especially on a lateral, but based on the patient size. We don't want to cut out any important anatomy. So lateral chest, he's holding onto the bar above his head. We can even see that inferior angle of the scapula there, and the central ray is set to kind of right at that level. And it's right in the middle of the chest. We see light in front of the chest, so we're making sure that we got all of that anatomy. We could even collimate this in a little tighter because we don't need any of this air exposed to radiation. So when I'm evaluating you, I'll be looking at your collimation, that the arms are not overlapping with the superior lung field over those apices or over those retrosternal clear spaces. The patient's not rotated at all. Sometimes when they're holding onto that bar, they can start to kind of sway, so we want to make sure that they're standing at a true lateral. We want to see that the long axis of the lung fields are vertical without any forward or backward leaning. They're standing straight. They have nice open thoracic intervertebral joint spaces, intervertebral disc spaces. They're sharp outlines of the heart and diaphragm, and they have pulmonary vascular markings from the hilar regions that are nice and visible. When I talk about intervertebral disc spaces, I'm talking about that space right in between each vertebra. That's the space where your intervertebral disc is. So if you've ever herniated a disc or you know someone who's herniated a disc, that's where it lives. And then this is an intervertebral foramen, and you have facet joints back here, so those are some more of those joints between vertebrae. The foramen, remember foramen means hole, so it's just a space where your nerves exit your spine. All right, so these are some images that show good and bad chest x-rays. You can kind of probably guess which one is not the best, and that would be this guy. His arms are out in front of him, kind of in a genie pose, but his clothing artifacts and his arms are overlapping with that retrosternal space. It's not nice and clear anymore. Versus this person whose arms are fully above their heads, nice retrosternal clear space that we can see. Next is the Lindblom method for A to P axial pulmonary apices. So we'll see an image of this in a second. But basically this is a method that's it's also called an apical lordotic. So we're looking at the apices, and the patient will be positioned in a lordotic position. Again, 14 by 17 and 72 inches. The patient position, again, will be upright, and they'll be standing about 1 foot in front of the IR and leaning back against the IR. The upper margin of the IR is now 3 inches above the shoulder border in the lordotic position, because now their body is at kind of an angle, and we don't want to miss out on those apices being on the image. So the IR should be 3 inches above the shoulder border. Again, a nice inspiration, so nice deep breath in all the way out, and breathe in again, and hold. The central ray will be perpendicular to the center of the IR and at the level of the mid-sternum, which will be about 3 to 4 inches below the jugular notch. So I'll show you where to find the jugular notch on the sternum. It's pretty easy to palpate on yourself, so you can palpate on the patient. Anytime you're touching the patient, whether it be that inferior angle of the scapula or the sternum in this case, which is going to be a little bit more invasive in their space, you're going to want to ask them for permission and let them know what you're doing. So I'm just going to be palpating your sternum here, so it helps me find exactly where to put the x-ray, so we make sure we get a nice clear image of your chest. So that's generally what I'll say, and I'll ask them if that's okay, and generally they say yes. We'll do collimation 14 by 17, again, smaller based on patient size. And in this case, we're looking for effusions between lobes of the lungs or apical lung masses. Because remember I said that sometimes tumors like to hang out in those apices of the lungs, and sometimes they can be kind of occluded by ribs. So it's important to be able to get this image, especially if we're suspecting that. So patient is standing kind of like this. Sorry, this is a little blurry. But they're standing about 1 foot in front of the IR, leaning back at an angle, and the central ray is going to be a little bit below that jugular notch. So notice here we have a really nice view of the apices of the lungs with those clavicles out of the way and with the ribs out of the way. We'll also note that because this is A to P, the heart is going to look a little magnified, but this is an accessory projection. This isn't part of our minimal diagnostic series. So generally this will be ordered in addition to those main chest imaging procedures. So this will be a P to A, a lateral, and maybe they'll tack on this as a special procedure if they're really suspecting that. So if you were to pull this for your competency, you'd want to make sure that collimation is appropriate. We're seeing, if we're looking at an image, that we're seeing clear vascular markings. The clavicles are above the apices out of the way. The sternal end of the clavicles are equidistant from the vertebral column. What I mean by that is, so nice vertebral column here. Each clavicle looks about the same distance apart from the vertebrae. If one clavicle was much further over, that would tell me that the patient's rotated, or at least leaning to one side. So if they're equidistant, then we know that they're properly facing forward. Ribs are distorted with their anterior and posterior ends superimposed. We can see that instead of that nice kind of oblique angle that the ribs typically sit at for a P to A, that they're sitting almost horizontal now. So PA and AP, the posterior and the anterior aspects of the ribs are superimposed. We can't really distinguish them from one another. Next is AP, axial pulmonary apices. So you might be wondering, why are we doing yet another apical view? This is not lordotic. That's a difference. We could do 14 by 17, 10 by 12, because this is going to be a bit of a smaller image. But again, 72. For sake of making things easier, I would remember 14 by 17. Again, we want them to be more upright. We're going to center the imaging receptor to the mid-sagittal plane, the level of T2. We're going to have them flex their elbows and place their hands on their hips, palms out, rest their shoulders on the back against the IR. Nice full deep breath in and hold again. And this time the central ray is going to have a tube tilt. So this is the first time that we're going to have a tube tilt. When we're using a digital machine like we have in the lab room, something that is different is that generally on machines that aren't digital, you have to kind of accommodate the SID for that tube tilt because it's going to change the physics of it a little bit. So when you're doing your competencies, you don't have to do that. But just note that if you work in practices where they have a machine that's not digital, which is pretty rare nowadays unless you're working in a small place, that you will have to move the tube a little forward depending on how severe the tube tilt is. But I'll show you how to do the tube tilt. The machine's really helpful in the lab for that. You're going to put it at an angle of 15 or 20 degrees cephalad. Remember, cephalad means toward the head, so it's going to be the tube's going to be facing more superior. You'll center it to the imaging receptor, and it will enter at the manubrium. So collimation, again, will be based on patient size. If we're using a 14 by 17, it should be 14 by 17, or smaller based on the patient. This is just another option for an image for the apices of the lungs. So notice on the last one, we still have, so we have a little bit of lung apex here. We still have a little bit of rib in the way and some superimposition there. So it just depends on the provider which ones that they prefer. Sometimes they'll order both, but generally not. But we have the ribs out of the way. We can see the apices nice and clear. Patient's not in a lordotic position, and sometimes, depending on the patient, they can't perform the lordotic position because of certain factors. Maybe an elderly person can't hold that position at fear of risk of fall. So this is a way that we can do it and still see those lung apices just by using a tube tilt instead. So when we're doing this, again, I want to see proper collimation, be able to see apices in their entirety. The superior lung region adjacent to the apices, the sternal ends of the clavicle, again, equidistant, make sure the patient's not rotated, and that the ribs, again, are superimposed. We can also do this P to A. So it'll look pretty similar. Again, you could do 14 by 17. You don't have to do 10 by 12. Again, it's 72, and then we want it to be upright if possible. We'll center the IR to the jugular notch. At the mid-sagittal plane centered to the IR. Patient will flex their elbows and place the hands palm out on the hips. Again, we're doing this to get the scapulae out of the way, and the shoulders will be rotated forward. They'll take a nice deep breath in and hold it, and again, they're going to have a tube tilt. So again, it's going to be 10 to 15 degrees cephalad, and it'll go through T3 to the center of the IR. So if you have a position or a setup like this that you're going to be doing that has a tube tilt, what I recommend is setting up the SID, setting up the tube tilt first, before you do any centering of the central ray to the IR or positioning of the IR. Because once you do the tube tilt, it's going to throw everything off. You're going to have to redo all your work. So just a way to save some time, and I'll show you kind of the pathway that I do to set up the machine as well that makes it most efficient. So you note that the PA axial looks a lot different. Note that it's also a smaller kind of spot shot. So we call it a spot shot because this is an image of the chest, but we have a much smaller collimation. We're not looking at the entirety of the chest. This is more so specific to look at the apices of the lungs. The kind of downside to this is that we still do have a lot of overlapping structures within those apices. We don't have a nice clear apex of the lungs, but this is a way of getting a little bit more detail by kind of cropping that image even shorter, using smaller collimation to get more resolution in those apices. So again, collimation should be appropriate. We should see the entire apices in the appropriate portion of lungs. We don't need to see the entirety of the lungs. So this is a case that although you're going to be using one standard sized imaging plate, we're going to make sure that we collimate tight. And I'll show you to do that in lab. We'll also want to make sure that instead of the clavicles being above the apices of the lungs, they're now located below the apices because of that tube tilt. So they're going to still be out of the way of the apices of the lungs, but they're going to be below in this case. Again, no rotation, and we should see nice vascular markings. Next is right or left lateral decubitus chest. For this, again, 14 by 17, 72 inches. The patient's going to be in the lateral decubitus position with the affected side down. If we're looking for something fluid related, generally there will be an indication on your on the sheet that you receive from the provider that has the order on it. So if they're suspecting a pleural effusion, some fluid trapped within the lungs, we'll put the affected side down. So if they have a cough and pain on their left side will go down. They'll lay on their left side. Or the unaffected side down if it's air related. So if we're suspecting something like a pneumothorax in a traumatic situation, or in somebody who has a congenital predisposition to pneumothoraces, then they'll put their unaffected side down. So pain on their left side, they'll lay on their right side. So if they're laying on their affected side, you'll use the table pad to help elevate them a little bit. Arms will go above their heads, and their body will be as close to the IR as possible, as always. The cephalic edge of the IR should be 1.5 to 2 inches above the shoulder, similar to when we were doing P to A and A to P chest. Again, we want this to be full inspiration. The central ray will be horizontal and perpendicular to the center of the IR as usual, and it'll be 3 inches below the jugular notch if we're doing A to P, or T7 if we're doing P to A. For the collimation, again 14 by 17, and then we'll adjust to the patient. So this is right or left lateral decubitus position. They're laying on their side. And this is helping to show kind of an accumulation of fluid. So we'll want to see appropriate collimation. Affected side is included in its entirety. We'll generally see a view of the entire chest so that we can see both sides. No rotation, their arms are out of the way, and again, nice visible pulmonary markings. So I know that was a lot. Make sure that you go through those though and you understand. If you have any questions, please come with questions on Wednesday or feel free to email me. I'm available through email. It sometimes takes me up to 24 hours to get back to you, but generally I'm a little bit better than that. So if you have questions on content or you're not really sure, please reach out. On Wednesday, we're going to go through this, and so if you're feeling a little overwhelmed at this point, On Wednesday, we'll be able to actually practically do it. We'll go through a review on how to use the X-ray units so that you feel more comfortable with that for your first competency next week. Okay? I do highly recommend, if you don't already have the book, to get the book and read the required reading each week. You will be using this book for future classes, and it's a really great resource for outside when you're practicing. It has all of the information in there, so you have your SIDs, you have your tube tilts if you have them, and there's even more images. So if you wanted to see exactly how something should be positioned or how it should look after the fact, all of that's there. So it's a really great resource, and if it's something that like maybe doesn't come across well over lecture, sometimes reading the textbook, you can kind of get that light bulb moment, and it makes a little bit more sense. So if you have questions, please reach out. Otherwise, it's the last lecture for this week, and next week we'll actually do it in person and every subsequent week.